PCI population, approximately 5% of them have atrial fibrillation. And no matter if you have a CCS or ACS, the risk of mortality will both increase to twofold if you have AF. And not surprisingly, if the patient have AF and combined with coronary disease, the chest VAS score and Hasbury score both increase significantly, meaning have a higher risk of stroke and bleeding. This is a research conducted approximately 10 years ago in Beijing Engine Hospital. And during that time, there's less consensus regarding how to prescribe patients with antithrombotic therapy for AF plus PCI population. But as you can see here, nearly half was prescribed with DAPT only. A quarter was triple therapy, and the other quarter was warfarin plus a single antiplatelet. But if we look at their adherence at 12 months, the DAPT and single antiplatelet therapy plus warfarin have around 92 to 95% adherence, but the triple therapy is really low. It's approximately half the patient will stop taking the prescribed medication. So for these patients, if you use a DAPT, you will dramatically increase the risk of stroke. On the other hand, if you use anticoagulation, the bleeding risk is not surprisingly increased. So a couple of RCT have been initiated and trying to figure out what is the optimized medication. The Wolf study compared, published in 2013 Lancet, compared clopidogrel plus warfarin versus triple therapy, DAPT plus warfarin, and it showed that while the ischemic endpoint were comparable, the clopidogrel plus warfarin have lower rate of any bleeding. And peritoneal AF, which is setting the new paradigm for this kind of a patient, compare with a P2Y12 inhibitor plus rivaroxaban. And for this is group 1, the group 2 is a DPT plus 2.5 milligram rivaroxaban. So these two groups show that they have a lower rate of primary endpoint, which is major bleeding or major or minor bleeding according to TIMI criteria, and also bleeding require medical attention. These translated might be part 2, 3, and 5 criteria, but these all three groups have a similar secondary endpoint, which is the ischemic endpoint of death from cardiovascular death, MI, and stroke. For the residual PCI, the population is quite similar to the pioneer AF. Half were ACS and underwent PCI, and the other half were the elective PCI. The results were quite similar. Dabigatran plus a P2Y12 inhibitor is better than the triple therapy in terms of bleeding, while the ischemic endpoint were comparable. And the Augustus trial is also compare another epizaban plus a P2Y12. This is a 2x2 fractional design, which divided the whole trial population into 4 groups. And in the end, epizaban plus clopidogrel is better than the rest 3 in terms of the bleeding endpoint, major or clinical relevant non-major bleeding. But the ischemic endpoint were quite similar. Finally, we have the Entrust AF PCI, which compared stable CCS or ACS underwent to PCA and endozaban plus a P2Y12 versus the warfarin-based triple therapy, and the primary endpoint is not surprisingly lower with endozaban plus a P2Y12 inhibitor, and the ischemic endpoint was also similar. So taking all the previous 5 major RCTs, the guideline has evolved. the latest European Society guideline on atrial fibrillation, published in European Heart Journal in 2020, suggested that in patients, AF patient with ACS, early cessation of DAP of aspirin with 1 week is reasonable if the patient is having a low risk of stent thrombosis, and then a dual therapy with OAC plus a P2Y12, preferably clopidogrel for up to 12 months is recommended. And for patient with CCS, still early cessation of the aspirin is reasonable, and dual therapy for a OAC and P2Y12 inhibitor for up to 6 months is recommended. And the 2021 North American consensus is a little bit more conservative, but still 1 month on triple therapy is recommended. Then a dual therapy is recommended for up to 12 months. As for the patient after 1 year, the AFR have compared the patient around 200 CCS patient, which is 1 year post PCI or CABG, and rivaroxaban for 15 milligram is better than rivaroxaban plus P2Y12 or a aspirin. Both the primary efficacy endpoint and the safety endpoint prevails. So I think we can safely use rivaroxaban for these patients when they are 1 year after the PCI. However, if we look at the real world practice, there's a lot of deviations. This is a JAMA Internal Medicine paper published in 2021, which reported the Michigan Anticoagulation Quality Improvement Initiative. These authors show that although there's guideline and a lot of consensus, still 1/3 of patients with AF are treated by DOAC plus and aspirin without a clear indication. As for the early discontinuation and low adherence of OAC in the AF plus PCI population, still a heavy problem, because if we look at the pioneer AF PCI, in the triple therapy group, nearly 30% of patients were low adherent to the prescribed medication. And regarding the group 1 and group 2, which is rivaroxaban plus APT, the early withdrawal is still nearly 20%, and that is in the Caucasian minority population. As for the East Asian population, I think the next speaker, Professor Zhang, will inform us the detail of East Asian paradox. But this here in the East Asian population, the East Asians will tend to have a less benefit while taking the antithrombotic or anticoagulation for reducing the stroke risk, while at the same time the bleeding risk were increased. So it's really a kind of a dilemma for the East Asian population to have the stroke prevention for AF. So could LAAO start a new paradigm for these kind of patients? However, current guideline does not support such an application. For the ESA guideline, still LAAO, it might be considered in stroke prevention in patients with AF, while they have a contradiction for long-term anticoagulant. And LAAO recommendation is only a 2B. And the same narrative appears in the ACC recommendation and is also a 2B recommendation. I think the major problem is the lack of evidence for LAAO versus the OAC, because the 3 major RCTs, PROTECT AF, PREVAIL, and PROC-17, which compared Watchman device to warfarin, and also the rivaroxaban, but the population was really small. On average, 400 patients were recruited per study, and so the non-inferiority margin was pretty wild. all of them have like 1.2 to 2.0 non-inferiority margin. So the conclusion is less sound. However, the Boston Scientific has sponsored a new trial called Champion AF, which will compare the latest iteration of Watchman Flex versus a DOAC. Approximately 3,000 participants will be recruited from 150 centers. Hopefully, we can see the result in a couple of coming years to finalize. To have a more confirmative result of the LAAO technique to DOAC. But before that, while we still don't have the sufficient evidence, as we all know, and also pointed out by the Professor John Kemp, which is editor-in-chief of the EuroPace, suggesting that clinical practice is always running well ahead of the guidelines. And while the patient, we are now currently doing the Watchman is absolutely contradiction for anticoagulation. Some patients, let's take it for example, the ones which have undergone PCI are kind of more unsuitable rather than contradiction because they are taking anti-inflammation drugs or DPT. And I think we should not wait until they have a bleeding event occurred, and until then we go to LAO. I think we can start more early because these patients, on one hand, they're not receiving a more potent stroke prevention strategy because they are less. Because the more side effect of the anticoagulation. On the other hand, the triple therapy or the dual therapy will cause more bleeding and causing their reluctant to adherence. The LAO in China and US has been both the boosts a lot, approximately 20,000 to 30,000. Per year has been planted in China annually. However, the clinical evidence in East Asian population is scarce. So myself and Professor Chao have followed 3,000 patients from approximately 40 centers in China, and we found that LAO in Chinese population is still associated with low adverse events. At 30 days, the event of death, stroke, and systemic embolism is around 0.52. And the 1-year result will be presented on ESC in late August this year. Regarding the post-medication, it's quite interesting. As you can see here, only around less than 10% of patients follow the ESA AF guideline. So we are still trying to figure out what happened and what is the impact of the non-adherence. Regarding the replace of anticoagulation to left AAO in PCI population, the evidence and the studies is pretty small or not so robust. But numerically speaking, PCI plus LAO is have a lower rate of deaths and other AE event. This is another study which used a two cohort. One is 150 around 150 patient with LAO. The other is 400 patient with AF taking medications. The author used a propensity score adjustment, and they found that LAO might be a reasonable alternative for the anticoagulation, but still we don't have the RCT level evidence. So our department have started a new trial called RECORD-2, which will compare LAO versus NUVAC in patients with AF and PCI in a randomized multi-center open label fashion, and this is a non-inferiority trial. The primary endpoint will be comparing ischemic endpoint at 12 months, which is death, stroke, systemic embolism, and myocardial infarction. infarction. And the secondary endpoint is going to compare the BARC-defined type 2, 3, and 5 bleeding events at 3 years. A total of 1,400 patients will be recruited, and now we have recruited 250 patients. So this is the last slide. I think the guideline is more conservative for the LAAO implantation, but the clinical practice in patients, while they have a preference for LAAO, or the patient is more refusal to take OAC, or poor adherence, or there is already a ischemic event while taking OAC, these kind of patient could be considered as a potential population to go to LAAO. But finally, I think, and maybe PCI population or the patient require a P2Y12 inhibitor might be another kind of a cluster of patients could go to LAAO. This is all, and thank you for